I think now we will move on to our next talk. So we have Rebecca, who will be talking to us about lupus. So staying on theme today for rheumatology for a little bit longer.
Great, so just let me share my screen here. Are you all able to see that? Okay, good. So good morning. This picture obviously has nothing to do with lupus, but this is where I grew up. So I grew up at the base of these mountains, hiking in these mountains with my dad, and this is home for me and where I was first introduced to autoimmune diseases. So my mom was diagnosed with rheumatoid arthritis near the time I was born, and has had one of the most severe cases I've seen. And then her twin sister later on in life developed limited systemic sclerosis, and her brother developed ankylosing spondylitis. So I've been confused by and interested in autoimmune diseases for a long time now. Today I'm going to talk about lupus. I think it's a fascinating autoimmune disease and in need of more targeted therapies. Oops. So I don't have any disclosures. I did put together a recent preclinical conference on lupus, and I'm going to touch base on a couple of the same things, but mostly I'll try to focus on new information. And by the time, at the end of this lecture, I hope that we can cover these basic objectives, which would be for you to be able to list the clinical and laboratory signs of lupus, interpret ANA immunofluorescent and multiplex findings, and describe the basics of the etiology of lupus, identify the types of rashes associated with lupus, and identify the classes of lupus nephritis and associated treatment. Review the workup for neuropsychiatric lupus, and have some strategies for treating mild and severe lupus manifestations. Let's see how this works.
I don't think this is lupus. It's infection, lupus, drugs, or cancer. No, I think lupus is way more likely. Treat him for lupus. That will get you fine.
You really think House is losing it?
Yeah. But it's not lupus.
ANA is negative for lupus. Again.
It could be an autoimmune disease. Lupus, Behçet's.
ANA for lupus, also negative. Lupus could cause...
No, lupus progresses slower. There'd be joint pain.
So it's not a typical case. We should get an ANA.
It's not lupus.
So that goes on for about like 5 more minutes. It's really funny. But so when is the diagnosis actually lupus is what I wanted to talk about. And since lupus can affect nearly any organ in the body, it can be a perplexing diagnosis to patients and physicians alike. So when trying to identify lupus, I first think about who is the typical patient who presents with lupus. So it's typically a woman in her reproductive years, usually ages 15 to 45. So if you see a man in his 70s and you're concerned about lupus, I would think more drug-induced lupus and look at his medication list. It's known that sex hormones influence the probability of developing or expressing lupus. So lupus is about 10 times more common in women of childbearing age than of men. But if you look at before puberty, the risk of lupus in men versus women is only about 1 to 2. It's also been shown in Klinefelter syndrome, where they have 2 X's, that there's a 14-fold higher risk of lupus compared to XY. And lupus has been shown to be rare in Turner syndrome. And also oral contraceptives, especially like high-dose estrogen contraceptives, have been shown to worsen lupus in a dose-specific manner. So gender plays a huge role. In terms of ethnicity, the prevalence is about 3 to 4 times higher in African American, Hispanic, and Asian individuals. You probably have all memorized this mnemonic at some point in medical school called SOAP Brain MD, if you remember, but essentially it lists the 11 1997 ACR classification criteria for lupus. And those being serositis, which means like pleuritis, pericarditis. Usually the oral or nasal ulcers are typically painless. They also can develop in arthritis and arthralgias. Usually it's non-erosive and non-deforming. Photosensitivity. The blood disorders in lupus are typically, you can have leukopenia, like lymphopenia mostly, anemia, thrombocytopenia, renal involvement. We'll discuss glomerular nephritis and other renal involvement in lupus. And we'll discuss more about ANAs and the specific autoantibodies. And then neuropsychiatric lupus is a big umbrella term for many different manifestations that we'll also touch upon. So there have been 3 different classification criteria for lupus. And just to remind you that classification criteria are designed to identify people to enroll in clinical trials. So they're not designed to make a diagnosis, but they can be extremely helpful when considering a diagnosis. But for patients with like mild cases and early disease, sometimes the classification criteria are not sensitive enough to make the diagnosis. But as you can see that the newer criteria are more sensitive in earlier disease than our previous criteria. So the first criteria were the 1997 ACR criteria, and you had to meet 4 of 11 of them. Then came about the SLE criteria, and you had to meet 4 of 17 criteria, or you had to have biopsy proven lupus nephritis and a positive ANA. And now the newest criteria that came out in 2019, I think it's really interesting that to even be considered as having lupus, you have to have an ANA titer at least greater than 1 to 80. And those are the ones that we use more now. So I wanted to touch upon like what ANAs are really. I know you all know about these, but they're anti-nuclear antibodies. These are antibodies that bind to proteins or antigens in the nucleus of the cell. And as you know, in general, the immune system produces antibodies to foreign proteins and not so much to human antigens. And I wanted to point out the distinction between the ANA immunofluorescence and multiplex and what they show you. So the ANA immunofluorescence will provide you with the ANA titer. The higher the titer, the more autoantibodies you have, and it will also show you the staining pattern. And how it works is they use HEP2 cells, which is a cell line derived from a human epithelial tumor. These cells are used because they have pretty large nuclei. The cells are permeabilized, and then you put the patient's serum, incubate it in the cell, and the patient's anti-nuclear antibodies will bind the antigens in the nucleus of the HEP2 cells. Then you add a fluorescent tag on, and so you can detect your antibodies. And ANA titers are reported as like 1 to 40 is low titer, 1 to 320 is a high titer. And that number shows how many times the patient's sera was diluted before the antibodies could no longer be detected. And so then the ANA also provides you the immunofluorescence with a staining pattern. And this refers to the distribution of the staining produced by the autoantibodies reacting to the antigens in the HEP2 cell. And so these are the most common staining patterns in lupus. And in general for the ANA staining patterns, not just in lupus, but in general. So, and there's many different antibody targets that can cause these staining patterns, but I've listed kind of some of the more common ones. So if you see the homogeneous pattern, if you look at the nucleus, the whole thing is diffusely stained, and this is often shows when you're targeting histones. So that can be in lupus, drug-induced lupus, RA. You can get this rim peripheral pattern. It's more indicative of antibodies targeting double-stranded DNA. The speckled pattern can often be seen in mixed connective tissue disorder, lupus, systemic sclerosis, and Sjogren's syndrome. And then the centromere staining pattern, you all know, is often seen in limited systemic sclerosis, and the nucleolar staining pattern often in diffuse systemic sclerosis. And this is the multiplex. So the multiplex will just identify specific antibodies against the autoantigens. And so, as you all know, the double-stranded DNA antibody is often associated with lupus flares and with lupus nephritis. The anti-Smith antibody is very specific for lupus, but it doesn't correlate to the level with flares. The RNP can be seen in lupus or mixed connective tissue disorder, the SSANB in Sjogren's and lupus, the topoisomerase in systemic diffuse sclerosis, and the RNA pol3, as we learned today, is often a risk factor for scleroderma renal crisis. So the multiplex kind of shows you what antibodies are identified. I just have a couple of slides about ANA tips. Just so you know, so in general, I consider ordering an ANA when I'm concerned about one of these like 6 diagnoses, and I have some clinical or laboratory findings that make me suspect one of these diseases. But it's good to keep in mind that ANAs can also be transiently elevated in viral infections. So you can see that a lot, that someone will come to you in a room consult and be like, this is a 1 to 80 titer, and does this person have an autoimmune disease? And they can often have a viral infection causing it. There's other conditions like autoimmune hepatitis, Graves' disease, that can cause a positive ANA. And just to also mention that ANA, I know you know this, but some people get confused. It's anti-nuclear antibodies, so it's against antigens in the nucleus, whereas an ANCA is against antigens in the cytoplasm. And this is a Pearl, and it's usually on questions on the USMLE and other ones, but that the antibody to the double-stranded DNA is what parallels disease activity, and increases can predict flares of lupus and lupus nephritis. There's always this question about what point is an ANA considered positive. Usually at 1 to 80 for us, it's more convincing. Obviously, the higher it is, 1 to 60, 1 to 320 really captures our attention. And then how often do positive ANAs occur in healthy people? It really depends on the ANA titer. So lower titers, a lot more people can be positive who are healthy. So if you have a titer of 1 to 40, about 30% of healthy people can be positive. And if you're over the age of 70, a lot of people can have a positive ANA at 1 to 40. 1 to 80, there's still about 10 to 15% of healthy people who are positive, myself included. So, and thankfully I don't have an autoimmune disease. So I think it's important to know that, you know, obviously the higher the titer, the more that you're suspicious for autoimmune disease. And then this is something, a Pearl, like I just wanted to point out, can a patient with lupus ever be ANA negative? It's very unlikely. It's extremely rare. So less than about 1% of patients with active lupus will have a negative ANA. About 10% of patients when they're treated with lupus can have a negative ANA, but sometime in the past they had a positive ANA when their lupus was active. So that's something to keep in mind when trying to make a diagnosis of lupus. And then these are some autoantibodies seen specifically in lupus and their clinical associations. And I know you know most of them, probably all of them. One that I will point out is the SSA antibody. Is good to know if your patient has this, because if it's a woman who wants to like have a child in the future, SSA antibodies have been shown to be able to cross the placenta, and they can cause neonatal lupus and complete heart block in the fetus. And so these pregnant mothers need to be monitored quite closely to evaluate for that. And then this is just a case I had, not one that I had pulled for, but just something I want you to all think about, and you can write it in the chat what your thoughts are, but just to see what the takeaways are from this ANA discussion. So this is a UW consult question that I had when I was on rheumatology, and it was a consult question for a 42-year-old man who had a history of IVDU, admitted with an AKI, liver failure, had Hep C, had tricuspid valve endocarditis, but the blood cultures were negative so far, and he had some emboli to the lungs. And somewhere along the line, someone got a positive ANA, and the titer was 1 to 80, and his complements were slightly low. And as we know in lupus flares, the complements can be low. And so there's this consult question was is this an autoimmune phenomenon going on? And I was just wondering if you all had any thoughts on this. So yeah, sorry, I have not been keeping up on this chat, which is great. So there might be some questions I have to answer, but yes, I agree. Doesn't sound autoimmune based on the person, and just based on if we think he has an infection, the worst thing to do for him would be to immunosuppress him for a question of lupus and make his infection flare. And yes, hepatitis C can cause transient elevations in the ANA titer, and complement can be low in lupus flares, but it also can be low in a lot of other diseases, as I've listed here, especially you know, your liver makes complement. So sometimes with liver failure, you can have low complement as well. And then this was another consult question that I had at UW room consults. And it was a 22-year-old woman who had some chronic arthralgias and low-grade fevers, night sweats, leukopenia. She didn't have any rashes, didn't have any swollen joints. She had a bit of a fever. Her white count was low and lymphopenic, and she had anemia. She had some elevated transaminases and a high ferritin. ID was involved and the infectious workup was negative. And we were consulted for, could this be Still's disease due to fever and elevated ferritin? It's not, and that's another discussion. But my question to you all was, would you order an ANA on this person? Yes, get the ANA, I totally agree. She is already meeting some criteria. So she is a great patient, and I'm trying to contrast her with the last one for a person that you would be considering lupus on. And just looking at the chat too, Hillary, I totally had the same question, and I think that's a great question that you had in the chat, and I don't know the answer to it. I've been asked that before, but I should look into that more. So we did get an ANA on her, and it returned back at 1 to 320 speckled. And the multiplex was positive for anti-chromatin antibody, anti-Smith antibody, anti-Smith RNP antibody, and anti-RNP antibody. So what do I have for my next question here? And I just wanted to bring this up, that whenever you see elevated transaminases in a patient with that you think has lupus, you should consider autoimmune hepatitis and kind of get your anti-smooth muscle antibody workup and IgG and all of those things, because they can often have autoimmune hepatitis. She also has a high BMI. I feel like it would be less likely for her to have non-alcoholic fatty liver disease at her young age, but that's also possible. But I would consider that workup as well in her for autoimmune hepatitis. And then my question to you all is, do you think she has lupus or mixed connective tissue disease? Because she has a positive RNP, and we've discussed that positive RNPs are associated with mixed connective tissue disease. So this is so for mixed connective tissue disease, about 90% have Raynaud's. This patient did not have Raynaud's. You see usually a really speckled ANA, just like this last patient. The anti-RNP antibody titer can be very, very high in these patients. They usually have swollen digits or synovitis. They can have myositis, pulmonary hypertension. So it's an overlap syndrome, basically mixed connective tissue disease, an overlap of lupus, systemic sclerosis, and myositis. It is a defined entity, and the important part to distinguish it from lupus is usually MCTD doesn't have like lupus nephritis. It doesn't have the CNS manifestations as lupus. And so it's nice to make that distinction. And a takeaway point for this too is usually if you have anti-Smith antibodies, it's usually lupus and not mixed connective tissue disease. And so she had positive RNP, but she also had anti-Smith. And so, and she didn't have some of these other findings. So we treated her and diagnosed her with lupus. But I just wanted to point out the difference here between those two diagnoses. And I also think it's important to be able to explain a new diagnosis of lupus to a patient. What I try to explain to them is that it can cause widespread inflammation. It can affect multiple parts of your body, and I list them because in different patients, it can affect different organ systems. And then I tell them that the seriousness of lupus can range to mild to life-threatening depending on the organs involved in the severity, and that it's a chronic disease and that they need to follow with their rheumatologist because of that. I've had a couple of patients recently that I've given new diagnoses of lupus to, and I asked them, like, have you heard of this before? And they've all been like, oh yes, Lena Gomez has it. And so I put a picture of her on here because a lot of them have been, following her and with her kidney transplant for lupus nephritis, and they have some kind of understanding of what that is. And sometimes it scares them and they all think like automatically they're going to have to get a kidney transplant. So I think explaining the etiology of lupus to a physician is much more difficult. One of the research mentors I had at NIH was a lovely man, and he was a rheumatologist and also loved the humanities. And anytime he talked about how complex the immune system was, he would quote Emerson, who had said something like, under every deep, a lower deep opens. And that's what he said he found when he did research in immunology, that every time he thought he found something, a lower deep opened and something more complicated and would come up, and he would realize that he was just at the tip of the iceberg and that there was so much to learn. So I don't want to spend too much time on this, but I do just want to point out, I think I have like 4 slides, a little bit more basic sciencey, and I try not to bore you and try to be clear about it. But basically, we know that genetic, environmental, and hormonal factors have been shown to affect both the adaptive and the innate immune responses. And in terms of genetic factors in lupus, it's long been known from twin studies that SLE patients have a high degree of heritability, and there are many different gene copy variants and SNPs that have been shown to influence the expression of genes involved in the immune system. And then that's kind of genetics. And then in the environmental factors, they've shown that UV light has been known to induce like lupus flares and alter T and B cell and innate immune responses, as well as different hormones like we've talked about. And I think in the past, there was all of this emphasis on the adaptive immune system in lupus, but more recently there has been focus on the role of the innate immune system in lupus and how detection of endogenous DNA by pattern recognition receptors can result in the production of cytokines and in type 1 interferons that significantly contribute to inflammation and organ damage. So here, just to highlight that a bit more, so we've known for a long time that there's a type 1 interferon signature in lupus patients. So these patients have high levels of type 1 interferons in their blood and in their skin. And probably in the last 20 years that they have found that there's these pattern recognition receptors in the cytosol of the cell called DNA sensors. One of them is called the cGAS STING pathway. And there are also DNA sensors on the endosomes inside of cells and also on the outside of cell membranes called toll-like receptors, which you probably heard more about. And so toll-like receptors and DNA sensors like cGAS and the STING pathway are really there to detect viral DNA. And then this viral DNA detection results in the production of type 1 interferons and cytokines. But recently they've been shown that endogenous DNA, like self-DNA from dead and dying cells, can also trigger these pathways. And this is a figure I made during my research to kind of represent how DNA is detected by these innate immune sensors. So you have these 2 DNA detection systems, the toll-like receptors, the cytosolic sensors. And basically, the cGAS pathway can detect DNA, endogenous or viral, in the cytosol. It goes through the STING pathway and results in your type 1 interferons and pro-inflammatory cytokines that causes this inflammatory state. And then also the toll-like receptors that can be in endosomes like TLR7 and 9, and they're translocated there by this UNC93. They can also result in type 1 interferons and pro-inflammatory cytokines when they recognize this DNA. So some of my research in the past has looked at this mirroring model of autoimmunity. And in this mouse model, DNase is knocked out. So these mice accrue endogenous self-DNA. And then they get these this very autoimmune phenotype where they'll get distal polyarthritis, autoantibody production. So to make it very simple, you can just think of the head as the control mouse and the DKO is the DNA accrual mouse. And they have very high interferons and pro-inflammatory cytokines. And you can see in the forefoot of this mouse how swollen it is with all this DNA accrual in it. And one of the things I looked at during my research was to see what, if any, DNA sensors were the cause of all of this inflammation. And so you can see in the control mouse, there's no inflammation. In the mouse with DNA accrual, there's a lot of inflammation in the paws of this poor mouse. And then if you knock out the cGAS sting pathway on that DNA accrual background, that you completely abrogate the arthritis in these mice. And that's also shown here by histology. This is an H&E histology section of the ankle of the mouse joint. This is the tibia and talus bones, and this here is your synovium, and it's usually in a wild type mouse about like a couple of cells thick. This is all fat cells. And then you can see in the DNA accrual mouse model how inflamed the synovium is here. And you can see all the inflammatory cells and here in the bone marrow. And this is another section showing a bunch of inflammation. And then if you knock out this DNA sensing pathway, the cGAS sting pathway, you completely abrogate the inflammation. And we also showed that you can, these DNA accrual mouse models have a lot of autoantibody production, and that the sting pathway is not responsible for that, but the TLR pathway in UNC93 is responsible for that. So overall, this is the last of my basic science. That's probably boring you, but DNA sensors and detection of endogenous DNA is important in lupus and in autoimmunity. And it's something that Keith L. Kahn, Dan Stetson, a lot of people at UW have been working on and have made a lot of great discoveries about. So a couple, I just want to see the time here. Great. A couple more things I wanted to talk about were the types of rashes in lupus. So now getting back to more clinical things. And just wanting to know if anyone could put in the chat if they know kind of the 3 subtypes of lupus rashes. Yeah, great. You guys are so good. So the one that you all think of normally is the malar rash, and we call that acute cutaneous lupus. So this is the rash that's strongly associated with systemic lupus. So this is your transient, non-scarring, typical malar nasolabial-sparing rash that's photosensitive. This is really indicative of active lupus, of systemic lupus. The other subcategory is subacute lupus rashes. Only 50% of these are associated with systemic lupus. It is a non-scarring rash as well. It can also often be drug-induced by antihypertensives. A lot of calcium channel blockers, ACE inhibitors can cause this. It's highly associated with anti-SSA antibody, and that there's 2 types, this annual and papulosquamous type. And then the third is the one you think of. So we classify these as acute, subacute, and chronic. And everyone thinks of malar versus discoid, but there's a lot of different ones in these categories. So the third is chronic. And this includes discoid, chilblain, lupus, paniculitis. And this one is permanent disfiguring scars, mostly on the face, ears, and scalp. And only 5 to 15% of these people actually have systemic lupus. If you know the singer Seal, I believe he had discoid lupus that caused scarring of his face. So this is just a bit about the arthralgias and non-erosive arthritis in these patients. So usually they have a lot of polyarthralgias, about 90% of these patients do. They can also have arthritis. The arthritis is usually not erosive. So in rheumatoid arthritis, you'll see these classic periarticular erosions on radiographs. But not with lupus so much. You can, with long-standing lupus, get kind of this more Jacquard's arthropathy that you've probably all seen. That is causes destruction kind of the tendons. It is reducible, as you can see. This patient can reduce it. So it's not like rheumatoid arthritis where it's non-reducible, but that can happen with long-standing lupus. But mostly you have non-deforming arthritis in these patients. So the next thing I wanted to cover was lupus and the kidney. So this is actually a poll question. I don't know how to bring this up, Lauren. Is that something you guys do?
Yep, I'll do it.
Okay. So this is a 28-year-old woman. She has low-grade fevers, oral ulcers, positive ANA, positive double-stranded DNA antibody, low complement, high titer antiphospholipid antibodies. Her UA shows some 1+ protein, not a lot, a few RBCs. She has a gram of protein in her urine. Her creatinine is at baseline though. It's normal, it's like say 0.7. So what would your next steps be?
We're still voting. We'll just give everyone a couple more seconds to wrap up.
Lauren, do I have till 10:40?
Yeah.
Okay, great. Great, love it. Renal biopsy. This is a tricky question, and I've been tricked on this before. So you can have lupus nephritis and you can have a normal creatinine. And so this patient would be very appropriate to biopsy, and you should biopsy her. I actually saw this patient, and she actually didn't have any protein on her UA, but she had like a few RBCs. Their creatinine was at baseline. And then we got another UA, and it showed like 1+ protein. And then we got a protein creatinine ratio, and it was around 1. And I was like, oh, she's probably fine. And then the rheumatologist was like, no, she needs a renal biopsy. We got it. And she had lupus nephritis class 4. So I will tell you about on the next slide about when to get a biopsy, but the answer is a renal biopsy. And you would want a biopsy before you went further for her. And also another reason I wanted to point out to biopsy this patient would be if she has antiphospholipid antibodies, she could have renal disease as well for microthrombi, which would, you wouldn't immunosuppress for that, you would treat with anticoagulation. So that's an important distinction to make. So the renal biopsy is performed. It shows lupus nephritis class 4. And what would you suggest for treatment? Which I think is another poll question, Lauren. I probably gave too many options here. I hate it when people give like A and B and stuff like that. I probably went too far.
I was gonna say, I don't know if our answer choices are quite lining up right with yours. So maybe I'll end this.
Okay. It's
I think we have a good representative thing already, but
it was A through D. Great. Okay. Well, we'll talk about treatment. Probably too far there. So usually for lupus nephritis, you treat with high-dose steroids and mycophenolate mofetil together, and we'll talk about that. Hydroxychloroquine is not going to touch it. Belimumab's not helpful. Rituximab's not helpful. You can treat with cyclophosphamide. It's just as helpful as mycophenolate, but it has worse side effects. So usually steroids and mycophenolate is the answer there. So these are indications for a renal biopsy in a patient with lupus. So the indication could be increasing serum creatinine without some compelling alternative cause, like without new medications or dehydration. Confirm proteinuria greater than 1 gram in 24 hours, which our patient had, greater or equal to, or proteinuria greater than 0.5 grams in 24 hours with hematuria. So you do not have to have an increase in the creatinine to have lupus nephritis. Because you want to diagnose it early and treat it early, There are useful serological tests. So double-stranded DNA often elevates with a disease flare and with lupus nephritis. So it's good to get that and good to look at decreased complement levels as well. But I just want you to know another takeaway point is that glomerulonephritis can occur in a patient with lupus who has normal complement and no elevated double-stranded DNA. And that's typically seen in lupus membranous nephropathy. So these here are the 6 different classes of lupus glomerulonephritis that you can have, different patterns. And I think the takeaway point is that you always want to treat class 3 and 4, but I'll kind of go over this a bit more. So class 1 is called minimal. It's called minimal because this class of lupus nephritis is rarely ever diagnosed. These people don't have hematuria, they don't have an increased creatinine, they don't have proteinuria, so there's no reason to biopsy them. It looks normal on light microscopy. You can have some IgG deposits on immunofluorescence, but essentially you'll probably never see class 1. Class 2 is mesangial proliferative. These patients can have some hematuria or proteinuria. Usually you don't have impairment in kidney function, and light microscopy will reveal this mesangial hypercellularity, and immunofluorescence or electron microscopy can show like a few mesangial deposits. Usually you don't need to treat this. Usually kidney prognosis is excellent. Unless you start progressing to more advanced disease or have evidence of like podocyte effacement, you don't need to treat it typically. Class 3 and class 4 are the ones that you definitely want to hit hard with your steroids and with your mycophenolate. So class 3 is focal proliferative, which just means that it affects less than 50% of the glomeruli that have been sampled. You'll have hematuria, proteinuria, decreased GFR, and on electron microscopy, you will see immune deposits in the subendothelial space. And then class 4 is just similar, but it affects greater than 50% of the glomeruli. This is the most severe form of lupus nephritis. All essentially have hematuria and proteinuria. You'll see, again, subendothelial deposits on electron microscopy, if you remember from medical school. And about 30% of these patients have a chance of progressing to end-stage renal disease. And then class 5 is membranous nephropathy. There on electron microscopy, you'll see subepithelial as opposed to subendothelial deposits. And these patients typically present with signs of nephrotic syndrome. What did I want to say about this? Typically, like class 5, you can treat with like antihypertensives, antiproteinurics, lipid lowering agents, diuretics to control edema. And there's some like gray areas about who to treat and when to treat, but I think essentially they decide to treat if you have class 5 and it's mixed with 3 or 4, like you have class 5 with 3 or 4, you always treat, or if you have kind of just a pure class 5 and it seems to be worsening and not controlled with kind of the antihypertensive diuretic therapy, you would treat. And then class 6 is kind of your kidneys fibrosed and it's a bit too late for immunosuppression to be helpful. So these here are the glomerulus under the light microscopy that I talked about. So you'll see class 2 mesangial proliferation. Class 4 here is this diffuse proliferative, and then you can also see on immunofluorescence in class 3 and 4 this diffuse IgG staining of immune complexes. And then this is class 5 membranous nephropathy. And then I think here on this next slide, I just show the electron microscopy that you can see for class 3 and 4. They have these giant immune complex deposits that are subendothelial, and then you can have subepithelial deposits here in membranous nephropathy in class 5. So this is the treatment kind of guidelines for lupus nephritis. So you do induction treatment with usually IV pulse methylpred for 3 days and then pred 1 mg per kg. And then you can treat with mycophenolate mofetil. People will start out at like 500 BID for a week because of like the GI symptoms, and then go to 1000 BID and then go up higher to about 1500 BID and stay on that. You could alternatively give cyclophosphamide. They've both been shown to work just as effective for lupus nephritis, but cyclophosphamide has a lot of worse side effects, especially one being the risk of ovarian failure in some of these women who are so young and want to have children in the future. And then after that, you can go to kind of a maintenance therapy with MMF or azathioprine. And I just wanted to point out just quickly about the renal disease and APS, that it can cause occlusion of renal arteries or small glomerular capillaries. And like I said, it's good to know that you have this versus glomerular nephritis, because the treatment is vastly different. Obviously, one's anticoagulation and one's immunosuppression. So And then one of the last things I wanted to talk about was neuropsychiatric lupus. And this is just a question I have, and just for time's sake, I'll just run through it briefly and we don't have to do the poll. But I just wanted to share this question because really this main stem is helpful for kind of patients that you'll see with neuropsychiatric lupus. So it would be like a 34-year-old patient came in with mental status changes with confusion, altered personality, forgetfulness, no focal neurologic changes. She takes prednisone, some plaquenil, and lisinopril, and she developed a malar rash and polyarthritis recently. Lab showed elevated double-stranded DNA, low complement. CSF is pretty normal, just with a slightly elevated protein. Her CT head's normal, her MRI shows some small white matter changes. And what's the most likely diagnosis here? It would be neuropsychiatric lupus. And we can talk about why on some of the next slides. Steroid-induced psychosis usually happens when you're over like 20 milligrams of prednisone a day. But that should always be on your differential on these patients on a lot of steroids. But basically neuropsychiatric lupus is confusing for everyone because it's this huge umbrella of like 19 different defined manifestations. The most common ones are like headaches, mood disorders, cognitive dysfunction, but you can have some, like about 5% can have severe cases of seizures, psychosis, strokes. If they have antiphospholipid antibody syndrome, they can have thrombosis and emboli that can lead to strokes. So I've put some focal and some of the diffuse manifestations that can happen with neuropsychiatric lupus. We don't call it lupus cerebritis anymore either. If you guys are wondering, we call it neuropsychiatric lupus now. The biggest takeaway point I wanted to give you all was that it tends to occur during active lupus. And so if someone's lupus is very well controlled, you don't have to be as concerned about this. There are many different autoantibodies associated with neuropsychiatric lupus that the rheumatologist might ask you for, and I have listed some here. And just in terms of the workup, like basically you have to rule out all other causes and infection. And then I would look for an active lupus flare because like I said, usually when their lupus is flaring is when they're having neuropsychiatric lupus. If you have focal neurologic deficits, it can be neuropsychiatric lupus, or if you don't have focal neurologic deficits, it can also be neuropsychiatric lupus, but it does help rule out steroid-induced psychosis if they have something focal. Usually all these people end up getting an LP. You want to rule out infection. In neuropsychiatric lupus, you're not going to see many changes. The only thing you could see is maybe the white counts up a little bit, maybe the proteins up a little bit. And then you can get some of these associated autoantibodies in the CSF as well that the rheumatologist may ask you for. Neuropsychiatric lupus can be associated with seizures, so you can get an EEG if you're concerned about that. Most of the time you get an MRI brain and MRI-A. You can get a black blood MRA to look for CNS vasculitis. But these are kind of the two pearls I wanted to take away that are in this box here, that if you, and a normal MRI does not rule out neuropsychiatric lupus in a patient with diffuse manifestations. And then it's unlikely that a patient would have neuropsychiatric lupus if they have a normal CSF, normal MRI, and no evidence of an active lupus flare. Oh, and then one thing I wanted to touch on super briefly is just pregnancy and childbirth, that women with lupus can and do have healthy pregnancies, so they're at an increased risk of miscarriage. And what I wanted to point out to you all, which I mentioned before, is that really look to see if they have anti-SSA or SSB antibodies, because those can make you think that they could passively transfer these to the placenta, to the fetus, and cause neonatal lupus and complete heart block. And then these pregnant mothers would need to be monitored for fetal echocardiograms every week during their pregnancy. And then I think this is my last couple slides, like last two slides on treatment, but just to briefly say that everyone should be on hydroxychloroquine who has lupus. It's great for skin and joint manifestations. It prevents flares. It has anti-thrombotic effects in APS. It's safe in pregnancy. It decreases all-cause mortality in lupus. It delays ESRD. The mechanism of action is poorly understood. Keith Alcon here has shown that it may bind like some of these DNA sensors, and that's interesting, but the mechanism of action is still, I think, in general, poorly understood. But it's a great medication for these patients. And then in general, to have some strategies to treat lupus, besides everyone being on hydroxychloroquine, is that I really think about treatment as if they have mild, moderate, or severe disease and think about the organs involved. So if they have severe disease and they have neuropsychiatric lupus, you're probably going to have to give cyclophosphamide. If they have severe disease like lupus nephritis, they're probably going to be on mycophenolate and high-dose steroids. If they have more mild disease, low-dose prednisone can help for that. Methotrexate can help for the arthritis symptoms. Belimumab is really the only targeted therapy they have right now. It's not the best therapy, but it's an anti-BAFF therapy that's been shown to be helpful, but not necessarily for lupus nephritis or the severe forms of lupus. So more therapies are more targeted therapies are definitely needed in the future. And these are just some pearls takeaway that I kind of mentioned throughout the talk that you can look in my slides that I think are helpful when thinking about lupus. And this is just my last slide, because if you talk to Dr. Gardner, he'll always tell you that rheumatologists are the happiest doctors. So I hope that that's the case, but it's a great field. So, and if there's any questions, sorry, I've been ignoring the chat, but.
Can you go back to the prior slide, the
sure.
takeaways? Just
Thank
Yeah.
you, Rebecca. These are such great slides too, and I have the slides so I can post them as a reference for the future too, because there was a lot of great info in there.
Great. Well, thank you all very much.